Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a patient who says, "Doctor, every time I brush my teeth or touch this side of my face, I get a sudden electric shock. The pain is severe, brief, unilateral, and then disappears completely." That clinical story should immediately make you think of trigeminal neuralgia. Trigeminal neuralgia means paroxysmal, electric shock-like facial pain in the distribution of the trigeminal nerve. The key idea is not continuous inflammation of the face and not ordinary dental pain. It is abnormal firing from the trigeminal sensory pathway, usually because the nerve has been focally demyelinated near its root entry zone. To understand it, think in 4 boxes: mechanism, clinical pattern, diagnosis, and treatment. First, the mechanism. The common classical cause is compression of the trigeminal nerve root by a blood vessel, most famously the superior cerebellar artery at the trigeminal root entry zone. This pressure causes focal demyelination. Once myelin is lost, sensory fibers become electrically unstable. Signals can jump abnormally between neighboring fibers, a process called a phaptic transmission. So a harmless tactile stimulus can trigger a sudden burst of high-frequency pain impulses. That explains the classic trigger. Light touch from toothbrushing, shaving, talking, chewing, cold wind, or touching a trigger zone activates normal A-beta tactile fibers. But because the nerve is demyelinated and irritable, that innocent input is misdirected into nociceptive pathways. The result is a sudden lancinating shock of pain. Now the clinical pattern. The pain is classically unilateral, severe, stabbing, or electric, lasting from seconds up to about 2 minutes. It most often affects the V2 and V3 divisions, so the maxillary and mandibular areas are more common than the ophthalmic V1 area. Patients may describe pain around the cheek, upper jaw, lower jaw, teeth, or chin. Between attacks, the neurological examination is usually normal. The key clue is the combination of very brief attacks, electric quality, clear trigger zones, and complete or near-complete relief between paroxysms. MRCP trap. If there is sensory loss, loss of the corneal reflex, weakness of mastication, bilateral symptoms, younger age at presentation, or persistent background pain, do not simply label it as classical trigeminal neuralgia. Those features suggest secondary trigeminal neuropathy and should prompt careful investigation. Secondary causes include multiple sclerosis plaques affecting the trigeminal pathway, cerebellopontine angle tumors, arteriovenous malformations, and post-herpetic nerve damage. In a younger patient, especially with bilateral symptoms or other neurological signs, multiple sclerosis becomes an important exam consideration. Diagnosis is mainly clinical. The history often gives the answer. However, MRI brain with trigeminal sequences is used to look for neurovascular compression and to exclude secondary causes such as multiple sclerosis or tumor, especially when the presentation is atypical. Do not confuse this with dental pain. Dental pain is usually more dull, localized, persistent, and provoked by percussion, biting, or temperature. Trigeminal neuralgia is usually sudden, electric, and triggered by light touch or movement. Do not confuse it with cluster headache. Cluster headache tends to be orbital or temporal, lasts longer, and is associated with autonomic features such as lacrimation, conjunctival injection, rhinorrhea, ptosis, or restlessness. And do not confuse it with glossopharyngeal neuralgia. That causes sharp pain in the throat, tonsillar region, ear, or base of tongue, often triggered by swallowing, coughing, or talking. Now treatment. First-line treatment is carbamazepine. Mechanistically, carbamazepine blocks voltage-gated sodium channels. This stabilizes hyperexcitable nerve membranes, suppresses ectopic high-frequency firing, and reduces the painful paroxysms. In practice, start low and titrate according to response and tolerability. Monitoring is important. Check full blood count, liver function tests, and UNES. Watch for drug interactions, hyponatremia, rash, sedation, and hepatic or hematological adverse effects. In MRCP questions, the treatment is not just give carbamazepine. The safe prescribing and monitoring are part of the answer. Alternative or adjunct specialist options include oxcarbazepine, lamotrigine, baclofen, gabapentin, or pregabalin. These are usually considered when carbamazepine is not tolerated, contraindicated, or insufficient. For refractory cases, or when medication is poorly tolerated, neurosurgical options may be considered. Microvascular decompression is the most cause-directed operation because it separates the offending vessel from the trigeminal nerve. In suitable patients with neurovascular compression, It aims to treat the underlying mechanism. Ablative procedures work differently. Radiofrequency rhizotomy, glycerol injection, balloon compression, and stereotactic radiosurgery reduce pain transmission through the trigeminal pathway. They can be useful, but the trade-off is the risk of facial numbness, sensory disturbance, and other trigeminal complications. If you remember one thing, remember this. Trigeminal neuralgia is brief, unilateral, electric shock facial pain, usually triggered by light touch, caused by focal trigeminal demyelination, and treated first line with carbamazepine. Quick recall. A 62-year-old patient has sudden electric shocks over the right cheek and jaw when brushing teeth. The neurological examination is normal. What is the most likely mechanism, and which vessel is classically involved? The answer is focal demyelination at the trigeminal root entry zone, causing ephaptic transmission, classically due to compression by the superior cerebellar artery. A 35-year-old has bilateral facial shock-like pain with reduced facial sensation and mild limb paresthesia. What should you be worried about, and what investigation is most appropriate? The answer is secondary trigeminal neuralgia, especially due to multiple sclerosis, and the appropriate investigation is MRI brain with trigeminal sequences to assess for demyelination, tumor, and neurovascular compression. Do subscribe to the channel for further videos.